Good morning, everyone. It's great to see you. Welcome to Ruby and Kevin's language class. Kevin and I were just laughing earlier about how to pronounce each other's last names. So we were going through a little bit of Spanish and Vietnamese, but we're glad to move on to policy and science. I'm so excited to introduce my new friend, Dr. Kevin Escandon from Colombia, recently arrived to Minnesota. He came late in December. He had met Dr. Michael Osterholm, and their work had overlapped on these topics. And Michael saw a gem in Kevin, and now Kevin is working here at the University of Minnesota. He's not in the School of Public Health with us, but rather in the School of Medicine. He's working with Dr. Tim Schacker on his HIV trials, particularly those related to HIV medications. So lots of important work being done here. I'm so glad that Kevin's been able to join us today. So his formal introduction, Dr. Kevin Escandon is a physician and an infectious disease academic and researcher trained in Colombia. Prior to relocating to Minneapolis, again, just recently, to work as a researcher in the Division of Infectious Diseases here at the university, he completed postdoctoral research training in antimicrobial resistance and provided HIV care in his home country. Amid the COVID-19 pandemic, he's also collaborated in research and policy-oriented initiatives with CIDRAP's Michael Osterholm and other expert epidemiologists and virologists. And I think that last part is particularly telling, and why I'm excited to have him speak with us today, because he really also, in addition to being an infectious disease physician, really does think like us epidemiologists. In fact, he's collaborated with some of our colleagues, for example, Ellie Murray, excuse me, at Boston University. So I very much appreciate the way that he has approached his work, and I'm looking forward to hearing from him today. So welcome again, Kevin.
Okay, thank you, Ruby. Let me know if you can hear me.
Yes, we can.
Okay, perfect. So thank you very much for the invitation. I'm very honored to be here. And okay, if you agree, we can get started now. Yep. Okay, so first of all, I don't have any conflicts of interest. And I would like to start the presentation with an equity statement. Usually, like we know, we have been like increasingly doing like territorial acknowledgements, but I confess that with 4 months here, I don't identify myself with Minnesota yet. So I was thinking more like an equity statement, which is quite related to this presentation. And so I will read this, but I swear that my slides are not this, has not this kind of text usually. Today I reflect on the social inequities rampant throughout the world, which greatly influence the COVID-19 response. Regardless of the pandemic, an appalling number of epidemics of discrimination and bigotry continue to plague the world. Poverty, machismo, racism, classism, homophobia, transphobia, and many others. All these social epidemics have a longer history than the COVID-19 pandemic itself. And because we are political beings, we have the power and opportunity to keep working toward more equality, equity, and justice. This is possible when we reflect on our empathy, inclusiveness, and ability to transform other lives. So you will see that I will cover many things in this presentation. Let's see how the time is going, and I will move forward if needed. But many of this is related to this equity statement. So let me see. Okay. So the agenda for today is I start with some terminology, pandemic, infodemic, and syndemic. They are quite interesting, especially the last one, quite interesting concepts. Then I will address some COVID-19 response challenges, and as well like some challenges in terms of science communication. Then I will mention some challenges in terms of the social science and the science policy interfaces. And the idea is that we wrap up with some solutions and some strategies, some good things as well, like actual things that we can do despite all the bad amid this pandemic. So I wanted to mention this public health case because I think it is one of the things that I most remember from the first year of the pandemic, and you can read it in the meantime, but it was about like a woman that was working as a cleaner in a company in Bogota. She was living with their two children at home, and they were not in school due to COVID-19 lockdowns and all this stuff that you quite well known. And her husband was a truck driver. He was working intermittently due to COVID-19 response as well. He then developed COVID-19 and he died. There was no funeral, and this caused like a burden, an emotional burden to the family, even to the kids. And then the family was infected as well. And when the mother tested positive, she remained positive. As we know, that can happen with tests for 2 months. So she could not be allowed to work. So you can understand, and it was a very poor family. So you can understand all the distressing that can be a pandemic, not only the virus, but all the social conditions and all the social determinants of health that we can see in just this case. So when we see this, we can remind ourselves of our privilege, because if we are getting COVID-19, I'm sure that we are not getting it in this context likely. So I want to start with some basic terminology. We all know now that pandemic is when an infectious or even a non-infectious condition spreads or is tracked in a number of countries that crosses international borders with a significant impact. But COVID-19 is not just a pandemic, it's also an infodemic, and this overlaps, especially when we analyze that we have been having an overabundance of correct and incorrect information. This has been quite pervasive to see all this throughout the 2.5 years that we have been with COVID-19. We have been working like on pandemic standard time, most of us, and the social and mass media have been quite a determinant of how information spreads. And the information uses the same holes that the virus uses. Us, like we spread the information as well. And it has been a huge problem like to have in this pandemic. Because when we have like an event of this size, the information that is spread is good, and it's also very, very damaging. It may cause confusion, anxiety, distrust, and cycles of violence as well. So we have now that a third concept that is syndemic, and syndemic is a very interesting topic, and it's all a field of study for medical anthropologists. This was first proposed by Merrill Singer in the 90s to describe a relationship between AIDS, drug use, and violence, because they were interacting conditions. It has been also used to describe HIV and tuberculosis, for example. We started to see it as well for COVID-19 around mid-2020. Of course, it was like that since the very beginning, but people were not using that term too much for COVID-19. And so what is a syndemic? A syndemic is a biopsychosocial synergistic epidemic where mutually reinforcing interactions exist between two or more health conditions. And this results from social inequity and power distribution. But one aspect that I want to underscore here is that syndemics are not global. Syndemics are patchy because they comprise only one part of the population that is affected by the pandemic already. This is key to the understanding of the concept that there are differential distribution of social determinants of health in this population that is affected by COVID-19. And therefore, the outcomes that this population will have will be different, will vary a lot. And when we see the syndemic perspective, we know that, let me see if, We see that there are some demographic variables and there are some context variables from the work, the physical environment, the governmental policies, the diseases or comorbidities that the patient already has. But all of these generate social disparities. And these are differential in many ways across all these strata of the population. And this makes that COVID-19 behaves as a syndemic because we have the medical crisis, let's say like the biological sphere of the infection caused by SARS-CoV-2, but also the other medical problems that the patients may have, but also mental health issues, and all the part related to finances and social life and behavior. And therefore, as I said, like COVID-19 is not inherently syndemic because syndemic is related to properties of a system. So it will depend on how that system is working for the people that are infected by the virus. And that explains this figure as well, because with the intention of showing that the syndemic is like the background in some parts of these overlapping figures, but it is not covering all of the COVID-19 pandemic. I will go over now to explain some COVID-19 response and science communication challenges we have had. This is numerous topics to cover. So I will be brief just to mention a bit of every one of these. But all of these communication challenges have affected our response and will continue to do so in the future pandemics that we will have. So to start, there are information disorders we usually call false information, misinformation, the information that is inaccurate or false. We also have some type of information which is harmful, which is regardless of the veracity, because it can be true or it can be false, is information that is spread intentionally to do harm or to deceive. And the overlapping section of those two bubbles is disinformation. That means false information, which is harmful as well. So that's the worst. Like that's the people who make claims that are false, but these are damaging. And in this case, this is damaging to the COVID-19 response. And we always will have this because of the two reasons that are essential, because people err in their thinking. So we will have always there are reasoning errors, but also because people also lie. It's not always, of course, but people do that because of interest or because of any other reason that they may have. And so that will lead that we will have always misinformation and disinformation about anything. But in a pandemic, this will be greater because we have much more information. We don't have like a consensus or like a uniform evidence, especially in the earliest stages of the pandemic. And one issue that is is quite shocking with these pandemics and all this science in real time when you are actually seeing it, how it works, is that you cannot stand the uncertainty. That's too difficult. And the evidence is changing so fast. So that makes the scenario the perfect scenario to spread information. And the consequences of these information disorders in a pandemic are multiple, of course. They influence everything, like if people follow public health advice, how they perceive the risk, because that will depend in many things. And that even depends on if they have a cousin that developed mild COVID-19, so they will think that they may have mild COVID-19 as well. So they won't, be compliant with some measures that some officials are recommending. Everything influences here, and also the fears and insecurities of these people. But the sad part is that they deepen social crisis. They expose the inequities and they increase the stigma that is around many other things in the society. They polarize and threaten democracy. So this misinformation is so damaging in many ways and adds problems to what we already have in this society. And importantly, also threaten decades of previous public health achievements, for example, related to vaccines, when you have like vaccination hesitancy or other phenomena like those, that's quite a big deal, and that's worrisome. We have seen disinformation of everything in this pandemic related to the origins of the virus, related to measures such as masks, for example, and also treatments. Many treatments that now is quite clear that don't make sense at all. But back then, they didn't have the minimum threshold of evidence to go on with a recommendation, but they were hyped in media, and people risk themselves by taking these medications that were not useful and are not useful for COVID-19. That includes, for example, hydroxychloroquine or ivermectin. And this was spread, for example, if you see this figure, it's like a cocktail of prevention medications that includes ivermectin and vitamins like and minerals like zinc, and all of this to prevent infection and also to treat in the early stages. And this, for example, is a protocol that is widely known, unfortunately, that is called Mask Plus, and is spread by two intensivists. There are two physicians that are, they got pretty famous because of it. And even now that there is stronger and stronger evidence that ivermectin doesn't work, they still are using this, and this is still on the website, and they are still recommending those treatments to their patients. Even if they got like a publication about it that recently was retracted from a very good journal, actually. And still now, like these headlines are from like recently this year. For example, insurance companies are paying for ivermectin, which makes no sense. They don't pay for other things, but they pay for ivermectin. Can you imagine that? That makes no sense. And also, many people continue to ask for it, or many other doctors continue to prescribe it because they believe that ivermectin is the panacea, which is so sad. And just for information, like yesterday, well, 2 days ago, actually, there was this publication, which is one of the largest, I think it's the largest, randomized controlled trial of ivermectin. And as we already expected, there is no effect of ivermectin on or hospitalization and other outcomes in this population, not even when you stratify, because you stratify by the time since onset of symptoms. Well, there was also this information, and this was a group of epidemiologists, and they were, most of them, infectious disease epidemiologists. They were thinking like this would work, like if you have an alternative approach to something that is very damaging and that everyone is hating, that is lockdowns. So you make things like, oh, you can like, you know, like do not do lockdowns and then just do focused protection. Like you know that the elderly are at risk, at greater risk. So you can have them in houses and you avoid them to get infected. And for many in public health and in epidemiology and infectious disease fields, we knew that this couldn't happen because these people are, first of all, they are living with others, they are not stopping interactions. And the other part that is very disingenuous is to not acknowledge that many other people, not only the elderly, may develop severe COVID-19. And you cannot know that. You cannot ensure that these non-old humans will be safe if they are infected with SARS-CoV-2. But yeah, this was so supported by people that they wanted to get rid of the lockdowns as soon as possible to resume life as normal. We have been also having disinformation about COVID-19 vaccination a lot, I think, and we still know that this is a problem, and this explains how delayed we are in terms of getting back to normal, and how damaging it is for our economies and our policies to get back on track and maybe, live with an endemic COVID-19 eventually. We note as well that there are disinformation super spreaders, and this is quite a nice term for this, because again, it's not only the virus that has super spreader events, as we know, it's also disinformation folks. And this was a report that showed that like among 400 people in Twitter, Facebook, Instagram, 12 of them contributed to almost 2/3 of the disinformation in these platforms. And so some policies should be directed to this specifically. And we know that disinformation is indeed harmful, as per definition. We know that because there have been studies that have shown that the intent of vaccination is lower when you have like exposure to misinformation. We also know by some reports of very good quality that this has an impact on the economy and many direct and indirect costs due to misinformation related to vaccines. And so I want to go over now with explaining a bit of the process when we have new information, and with our senses and with our emotional perception and our reason, we ended up like processing this information, interpreting it, and then like establishing some beliefs, making some arguments, communicating with others, taking decisions, doing like these behaviors. And this is, of course, not as simple as it's here. It's complex, it's messy. You get feedback, you change, you hear, you rethink about this. But this is nice to know that in these gray arrows is where you can find the cognitive biases and logical fallacies. And this will influence a lot how you think, how you process this information, and how you ended up like believing in something that is quite different to what the other guy thinks. And this has been quite described. This is a very nice review that is quite recent from this year. I shared this with Ruby because it was quite interesting, and it's how we have drivers of false belief, and these false beliefs are emotionally, they are largely supported by emotion, but they are also driven by many cognitive drivers and intuitive thinking. So when we see cognitive biases, we all have cognitive biases, of course, and some of these are very complex, and we are not learning this unless we are like cognitive psychologists. But we should know that these influence our thinking, and they are there. We should try to identify them and don't get like led away from rationality. We have confirmation bias when we hear or read what we want to be like in agreement with our thinking already. When we have some information and we have this information available and it's easier to pick up and to make a decision on that, we also have like availability bias. And we also have anchoring bias, where we are anchoring to one or two beliefs and we are not moving from that. We are just staying there. Even if we get better arguments, we just don't care. So those cognitive biases influence this a lot. We also have logical fallacies, and we have been hearing this a lot, like these flaws in the arguments, where for many people that know about the topic, this doesn't make sense. But for those who don't work or who don't know about vaccines, for example, makes all the sense in the world, and that's fine with them. And that works with them, because in the end, what they don't want is to get vaccinated because of other reason, because of distrust, but the logical fallacies made the case, so they are in line with that thinking. We have seen a lot of like logical fallacies, from appeal to emotion to false dichotomies. We have all of them. We also have conspiracy theories, and these are very interesting because they are complex. They are quite complex, and they refer to explanations for situations that are, in appearance, they are they are involving conspiracy, which conspiracy is a real thing, but in this case, it is not happening. It is just the case that it seems to happen because it's likely for those people, even if there are more likely explanations for that. One of those is believing that climate change doesn't exist, for example. And in the case of COVID-19, we have seen quite a lot of this. They are interesting because they resist falsifiability. Even if you have the arguments, they work pretty well to stay where they are. And they gather these followers that are like so stubborn in terms of politics, religions. So it's very interesting to see how it works actually. And there are two phenomena interesting for conspiracy theories. One of is what we call the proportionality bias. And it's because if you have big events, it's because there must be certainly like big causes, like that must not happen from zero, right? So that will explain that a pandemic like this is a huge thing that I never left because this is the first pandemic in my life, which is not true, right? But so it's because there is a big cause and there is like a conspiracy behind it. And the other thing is if this goes with the government or with some political ideology, so we are going to keep feeding that line of thinking, and that's what we call confirmation bias as well. So this influences a lot the conspiracy theories, and we saw that with the pandemic when Judy Mikovits, she talked about this, that the virus was manipulated and it was someone very strong scientist behind this. We also saw this when the conversation was about microchips, and they made the analogy with with softwares and other technological platforms, like it would work like this way, and it would be to then like sell vaccines, right? So it's the same like the viruses, but for computers, which doesn't make sense, of course. We also saw that for 5G claims, this was interesting because even they did the RN study, they did the first ecological study, really, like they make these spurious associations where you have 3G, 4G, 5G, and this just was the same year where you have any outbreak, whatever of the tens of outbreaks you may have. You just pick that data and you just think that it may happen after that outbreak. So it is because it's tied to this technological development. And then you see a map of the US and you see that there are some correlation, no causation, of course, between 5G and coronavirus. And people don't think more further than that, just to know that the cities where there is, of course, a higher number of citizens is where you have, of course, these 5G technologies. And of course, this explains why this is correlation. There is confounding, if you want to call it like that. But so it's quite interesting that people believe in this. We also have false dichotomies when people polarize things and just give two options where there is something in between that you could choose, that you could analyze, think about it, but no, you just don't do it that way. You just have to choose a side, So we published this paper almost 1 year ago. Many of the parts still apply and will be very useful for any other pandemic that may emerge in the future. Of course, there are sections that are quite outdated now because COVID-19 evidence moves so fast. I will not go over this now, but you have the reference if you are interested. But I will cover some of the most key aspects of this in the following slides. So we have also this polarization between bands, and of course, this was supported and spread by our political leaders in many parts of the world, not only in the US. We saw how they changed from saying that the coronavirus was under control and it was going away next day to then saying yeah, some people have the blame and unfortunately, like this week we have to report like there are like 400K deaths. So how is that we are so responsible to not believe the experts when they are first letting us know that this is happening, and then we are really in a mess. And also the intolerance of uncertainty mentioned is a huge problem, especially in a pandemic. But we live with uncertainty all days. We just cannot accept it now because it's just too much when there are lockdowns and there are many things that are just not convenient to us. We have seen like what we call armchair epidemiology, and maybe the elegant way to call this is epistemic trespassing, when like people, they can have like a PhD or even be a Nobel laureate, but if they are a Nobel laureate in black holes, why they are like giving public health advice if they don't have the minimum training to understand things? Some of these claims by many of these people have been so damaging for public trust and for having people follow advice. And it's because some of them, of course, they want the Twitter with 1 million followers, and they also have financial interests. They just want to put some clickbait that says like Musk will end the pandemic this summer 2020, and that's what people wanted to hear. That happened, and that continue to happen a lot. Or because now is what we're seeing now. So we have the Omega, eventually we will have this, the Omega variant, and we just say that it's deadlier. And okay, this is a clickbait because people want to read that. They are very concerned about it. We have been having the issue with ivermectin that I mentioned. And it's surprising how this end up having this support as a safe, effective drug when it's not, or being recommended so widely. I think that I just already had explained this. I'm not sure that I had this slide before, but the anti-science movement are increasing, and this is a huge problem, the science denialism with everything, because this even denies the Holocaust. And this is serious. Denying the Holocaust is serious, but also the climate change, AIDS, and now vaccines. And this is a huge problem that we have to take care of, because we will see this with every other thing that will come to our lives in the following years. And these cycles of distrust are so worrisome, because they deter the efforts at correcting misinformation. So we can try to educate the public, but it will be hard to get back on track and gain the trust from those peoples. And when I mentioned the 5G conspiracy theory, one would laugh and say oh, that's so silly. I didn't believe that. But there are people that believe it. So if you have a conspiracy theory saying that 5G exists, you may have people that then solve this 5G BioShield USB key to protect you from the 5G. So this is a business. People are, they are taking their part from the pandemic. This is dishonest. This is damaging, but people are doing it. So this is quite interesting, seeing all these phenomena. So this is some of the COVID-19 challenges that we face and then we may keep facing every time. But now I want to go with the interesting part of this talk, and it's the social sciences part. When we have science and policy, we usually would think this is two separate fields. Of course, they are not. Of course, they are rather related to each other. And sometimes they are actually, I would say many times they will be overlapping, because one of the purpose of science is to inform policy. But it's not easy, it's not straightforward, it's complex. And all this in between, overlapping between these two bubbles, is what we can call science policy interfaces, which is, in other words, like the ways in which scientists, policymakers, and other actors exchange ideas, communicate, and develop this knowledge that is useful in the end to enrich the decision-making processes. And there are, of course, many challenges because we have in the science, the scientists that have like this specialized knowledge. We have in policy other folks that may not be with that specialized knowledge. It wouldn't be like more like, the political folks. They have other interests in other things. So of course there are like challenges in terms of communication and the difference between these disciplines in terms of applicability, values, positions. But there are solutions in terms of communication and some interdisciplinarity. So we have useful policy making that is evidence-based. That's the last purpose with this. And very unfortunately, we have to talk about trade-offs because sometimes, and in this pandemic, we need some quite evidence fast, but we don't have this evidence now. So we start like being with the preprints and all these songs and all these things, like they are spread quite fast, but they may be wrong. So we pay the price choosing one over another. So there have been like at least three trade-offs in this pandemic. One is clarity versus complexity. And you can be simple, but you could also like be convenient and uncertainty, but people won't like the uncertainty. So you have to, weigh this and decide where you are getting the message. Also the speed versus quality. And this was so evident in the pandemic, especially in the first stages. And also data versus assumptions. And it's because the data is not available in the first month, for example, but you may work with some assumptions. For influenza, for example, which for COVID-19 didn't work, of course. And we ended up like with public health, which is in the end, this application of the science that is beautiful if we do it right. And then I get to this to show you that sometimes we talk about like a society, but and this society has some health and some disease, but this does not exist in a vacuum. This rather like is in the context of what we call the social determinants of health and disease. And we really know that how we live, how we are educated in the neighborhood that we are, that we grow up, or the place that we are born, that will influence our happiness, our health, our opportunities, our quality of life. So this is a big deal because this defines everything. And still is not being paid the attention that it deserves. So it's quite different depending on many social things. We would expect that at least things would be distributed equally. That would be like, like the basic thing, right? We want at least equality. We don't have it. We would then wanted equity. That is being kind of fair and distribute things to those people that need most, which makes total sense to me. And I guess that to you as well, if you are public health folks. In the end, thinking how you can make justice when there are unfair systems. But the sad thing is that we are not usually seeing any of these three scenarios. We are seeing the reality, which is quite unfair, where the richest have more and the poorest have less. That applies to everything. And all the system of inequities and inequalities are really systematic. Many of those things are avoidable, but they are not being fixed. So one concept that is quite interesting is intersectionality, when we know that people may have one of these, for example, different categories. Of course, they are more vulnerable if they have more of this, because they belong to groups that are influenced negatively to have some, for example, COVID-19 outcome that is worse or less access to healthcare. This is what we call intersectionality. And this defines something that is privilege and inequity. I will read this fast, and I think it's quite appropriate given us even the situation with Ukraine. So do not forget, you were born in a corner of the planet with no natural disasters or hostile environments. That you were born in a time with no constant armed conflict, in a family that was able to feed you and educate you, and you didn't earn that yourself with your effort. Your starting point was a gift. Sometimes we don't see the privilege, but the privilege is something that is quite relative, and we are definitely privileged only because we are in this Zoom meeting now. And when we analyze all this system, when we analyze all this, we are in a system of unfair power and privilege distribution. And one of the biggest issues here is colonialism. So this is quite interesting, but I don't have the time to go over it, but I will give some advice in the end. And the social determinants in the pandemic, in the end, they influence effectiveness, the real world application of all these things, the clinical outcomes, the barriers, the access to health systems. And they are often worse than the COVID-19 pandemic itself. And they existed before, and they will stay on. We cannot forget this, because these social determinants, for me, are everything. And this explains why. Just to show you some interesting issue here, and there is a region in Peru, in the Amazonia, which is Loreto. So this is the rainforest, and it's the main rainforest in Peru. It's beautiful, of course, but it's also very poor. And so when COVID-19 hit, there will be these Kukama indigenous people, and they made these visions of coronavirus, work with different journalists and indigenous artists in different countries of Latin America to depict how they perceive the pandemic. This is quite interesting because this explains many things. They show how the corpses at the foot of the road, and their, the black mantle of a carrion, and people escaping on foot or by boat into the forest. In front there were the gods of the jungle, represented by the jaguar and the snake. And also how they managed to be there and to know that the people were dying because no government was available, were accessible with a COVID-19 response plan for them. So these are social determinants in pandemic. This is public health inherently. I saw a presentation recently in a mini medical event from Dr. Henry Smith, and I just took this link and just to show you that rural versus urban COVID-19 outcomes are an issue here in the US as well. As you can see, more deaths and also less vaccination rates. And this is important because this shows that there are differences. Even if this is confounded and there are many things, of course, behind this, this is showing that something is going on. And we know that because it's not the first time that we know that rural health is differentially affected versus the urban health. We know that the virus causes inequality and thrives in it, and we know, for example, that is different between men and women. We know that as well, that there would be more deaths in populations that are marginalized, like Afro-descendants and Latinos and Black people. We know that lockdowns and many issues that people didn't get some economical support from the government, they also cause some protests, and these are very legitimate protests, because if you don't have something to eat, how you expect to be in the house following advice and doing the quarantine? That makes no sense. We have had this pandemic fatigue when we are told that the lockdowns are still going on, the schools are still closed, or nothing of this is changing every time soon. And also when people is blaming, shaming, and stigmatizing you, that doesn't work in public health. So to wrap up, what I want to show you is that it would be desirable to see different parts of this elephant when you just don't know that it's an elephant. Maybe you get a whole picture of it. You just don't need to stay with the whole elephant. You just can go back and then like prioritize one part. But to do this, you have to see the whole picture. That's what I want to say. So it's not like a being in the middle always. It's more like a going to the middle to know what is on your left and on your right, and then you decide. But you need to know the context. You need to know what is happening. You need to analyze your cognitive biases. So that's what I want to say with middle ground. It's not like you have to be like always in the middle and you cannot go to one way. It's not that, of course. There are strategies against misinformation. I will skip this. Just we have some space for questions maybe. We'll focus on prebunking. Prebunking is kind of analogical to immunization because actually it's exposing people to some weekend misinformation, and they are warned that this is risky and that will happen. So when they are exposed to actual misinformation, they are protected. So this is kind of a nice cognitive psychology approach, very useful in terms of strategies, because the traditional one is debunking, and debunking may work, but sometimes it elicits like people, they just don't do nothing. They just don't care. You can correct them and just say, hey, this is false because this is what is true, but they don't care. They will keep like their thinking. That's called actually continued influence effort or continued influence. I forgot the word now, but it's when you have this information like the same, you didn't just change it. And sometimes it could even be like elicited and be worse. That is what people call sometimes backfire effect, but it's quite not proven in the empirical studies of cognitive psychology. So I will wrap up with this. Like I have other slides, and this can be like share if you interested. But like I'm skipping a bit because of time. I know that I have more slides for the hour. Just to mention, like we have to revisit the COVID-19 policies, and this may not be a perfect paper, but the one message with this is, we need to adjust our policies depending on the context and depending on the time of the pandemic, depending on the population as well. We need to, like, you have to ask some things to the population, but you need to give as well, because people are not eternally believing in you and expecting that this is going to be over if things are not changing. They need that. And so we need to mitigate the pandemic, because we know that we are not eliminating or eradicating at all. That's quite clear now. And we need to move on with our lives. But so we have to find this balance of doing it safe. And so we need to adjust policies in the context as well. And this was about the colonialism that I briefly mentioned, and it's because one of the imperatives of change in the wake of COVID-19 is thinking that we are in a colonial war because of neocolonialism. But there are many issues that are like hidden, this system, these patterns of racism, inequity, patriarchy, and we need to explore this, how we get to the other side. Of course, it's not a on-off event. It's more like how well we are doing it, how far we are getting. It's not yes, no, it's not dichotomized again, but it's an event that we have to start working on, because this explains many of the social unfair things in our world. So as a conclusion, we need to know that science is not binary or simple. There are uncertainty always. It is unavoidable because it's part of science, but should be tolerable if we are expecting it. We know that the pandemic is critical and we have to address it. We have strategies to do it. It is not hard. It's not easy to change people's minds, but there are strategies and we need to keep working on that. As well for communication, and we need the experts on this to be effective when we do it, and be transparent, have nuance and acknowledge uncertainty. We all need to incorporate all these elements. Recognize the syndemic aspect, that we amplify inequities in this pandemic, and we are doing it always with the policies, because policies are not perfect. We are making damage with policies at some point, and that's expected, but we have to be the best we can, I guess. And these policies, to do that, we need to base the policies on actual evidence and social contexts. Remember that we are not in a vacuum, we are in a context, so we need to adapt that to the context. Okay, I think I can finish now. I think I'm kind of fine.
We have plenty of time for questions. Kevin, thank you so very much. And thanks for being a good sport despite the interruption. So I appreciate that. I open the Zoom to any questions that you may have. Feel free to unmute and ask your question, or simply put it in the chat box and I am happy to read it. Kumi, do you want to unmute? Else, Kumi, I can read it.
Yeah, no, I'm happy to. I just wanted to thank Dr. Escandon for the really great talk. And I wrote that I was really struck by the similarities between what it takes to prevent an infectious disease pandemic and then all of these other challenges you mentioned, because it seems that the way to prevent and fight these, pandemics of information or disease, it's like a lot of slow, democratic, unseen labor that can also be undone so quickly. So I was just really curious. You've provided great lists of strategies that we could kind of start to use, but I was curious if you've seen examples of places where those types of strategies of either prevention or fighting kind of, conspiracy theories, infodemics, misinformation. Have you seen examples of where that's been kind of carried out more successfully, or things that give you hope?
So thanks for your question. Briefly, no, I have not seen that. I may have missed it, but the cognitive psychologists that have worked on these topics, that they do these empirical studies, like measuring the impact, for example, of debunking or prebunking. And you may have fact-based, source-based, logic-based prebunking or debunking. And they measure this in well-designed studies and these things. I have followed the publications over the 2 years, several of those groups, and I have not seen something like that, at least in a big spectrum of related to COVID-19, public health advice and policies. It could be very interesting to do it, very hard as well, I guess, but I'm not aware of those approaches at all.
Thanks. Yeah, no, that's disheartening, but confirming to hear.
Yeah, and what you say is really, it's quite staggering, the comparison, right? In terms of the spreading, because the virus is infectious and the misinformation is as well. And what I show, for example, the term prebunking is like inoculation, so it's like a vaccination. So it's quite interesting, and the same, the effect, how lingering, how prolonged is, how we are not getting away from the misinformation, and we are not getting away from the pandemic as well. It's quite interesting how related it is. I mean, it's because the virus goes with the misinformation itself. Yeah, it's quite interesting.
Thank you.
Jim, would you mind unmuting and asking your question, or would you like me to do it?
No, I can unmute.
Thank you.
So my question was, as scientists, we deal with uncertainty in sort of our everyday work. It's a natural thing, but a lot of the public seems to be uncomfortable with this idea. And so my question is, are there things we can do to help the public feel more comfortable with uncertainty as a feature of science?
So about it, and the other question, there has been research on that a lot. I think quite enough. We acknowledge that scientific uncertainty is an issue that we have to deal with. And I saw a couple of papers, I think, from last year, and what they are saying is we have to acknowledge that, because that's part of science, of course, and we needed to do it because that may encourage public trust, for example. And that I remember that there were some letters to the editor saying oh, but people, what you just said, people don't want to hear about this uncertainty because they just don't want to know that we don't know. They don't want to know the expert in TV saying we don't know what is going to happen, even if that's the fair thing to say. they want the other expert, pseudo expert, likely that is saying like, oh, the pandemic is ending tomorrow, and if it's ending by my birthday, so I'm very happy because I'm having a great time, right? So it's how it works, the complexity of what is convenient to us and how we can differentiate that. So I think that the response to what you just asked is not easy, but it could be like summarized in education. And the S is getting used to that. So everything is depending on if you are in a home and you're educated by your family and you know how science works, how messages are communicated. If you read this and you know that you didn't take ivermectin because you know that the drugs don't work like that. You have like phase 1, phase 2, phase 3 studies, you know, risks, and you know something like that literacy, but also like you don't have like these financial gains of selling 5G USBs. Because if you are like in a situation of poverty, how can I ask you like you don't take what you find, you hit the business with the COVID-19 pandemic. So you get what I'm saying, like all this social context matters, because many people would like justify these honest actions or some of their biased thinking just because, for example, the government didn't care for the well-being because just closed schools and issue lockdown. So for me, it's everything of it. But I think one of the main reasons is to do more education, of course, and that's long-term, of course. That changes through generations that we won't see the impact of that, but we have to start to do it and to improve it, I guess.
Kevin is also an editor at PLOS Global Health, and you did a fantastic job summarizing how across the globe we've acted uniformly with misinformation and disinformation. Can you think of any examples that were either country-specific or region-specific in differing responses to misinformation? Because one thing I've been struck with is how across the globe, how uniformly people have taken in misinformation and disinformation. And I'm wondering, as the editor or what you've seen or from your time in Colombia, if you saw any types of different reactions in regional settings.
No, that's interesting, Ruby. No, I have not, like, I don't think that I have looked at it like that way. I do know that we know that there are differential impact of responses between countries. And we knew that from the very beginning, the pandemic, when we know like Asian countries, like they were more compliant with masking. And in the US and also in Latin America, like we took our time to believe that everyone had to use a mask. Of course, the discussion became so complex then to know what is a mask, what is a face covering, what you are doing really with what you are wearing, because you can wear like a bandana, but that's not protecting you. So it became more complex. But we know from the very beginning that it was so easy to expect that Asian people wore a mask and didn't complain because they were asphyxiating or they were like being violated of their freedom because they are wearing a mask. I think that happened here in the US because everything is so polarized, of course. So I know that there were like differential responses in these countries to those things, but as like the first person that did a question about the misinformation associated with that, I don't think we have the information about it. That's quite interesting thing to know, but I'm not aware of those approaches or those studies actually.
So Kevin, it's been a pleasure to have you here at the university and here with our seminar series today. So thank you so much for your time. And I very much encourage anyone who's interested in Kevin's work, as you saw in his citations, that he was the author or co-author of many of the papers that he presented as well. So feel free to reach out to him. So thank you so much. See everyone next week. If you want a recording or watch the recording of this seminar, it will be available next week. Take care. Thanks, Kevin.
Thank you. Thank you so much for the invitation.